So very good afternoon to all of you. First of all, I have to thank the organizing committee, Dr. Asha and everybody for giving this opportunity. And it's good that this rehabilitation is now a norm to include into the main conference, because these topics are usually neglected when rehabilitation, gait analysis, because whatever good surgical techniques which you have followed, and if you don't give a good rehabilitation for that patient, it will not give a good results. So I was asked to speak about what's new in ACL rehabilitation, because we all know the standard protocols. And we'll start with this, the success of any surgery is the race between the biological healing and the fixation failure, which occurs first. And we all know that the effects of disuse, that because of immobility or immobilization, the collagen fibers, they will decrease in size and amount, and they will have a random orientation. And once that activity happens, then the collagen fibers, they increase in size as well as amount. Their orientation is correct, and that only gives the increased strength. That suggests you how important to have an activity, and very important to get the balance right as well. You should try to avoid the muscular atrophy, get a good muscle which they try to inhibit their muscular actions, and avoid any poor neuromuscular control which usually happens. So you have done good surgery with all the previous excellent techniques which are suggested. The further procedure is to understand how to move ahead with the physiotherapy. I think it is very essential. You should have a good team approach with your physiotherapists, with your colleagues. Physiotherapy should always know actually what kind of surgery we have done, because the routine trauma cases, joint cases, where you go for the x-rays properly where they can see, but arthroscopic cases, they don't have any idea what is gone inside. So they should be able to understand that is what kind of injury it was, what reconstruction, which graft were used, the patient, the pre-op education, their supervision, and important to have what are the associated injuries. Very essential to take these OT notes which are readily available with them. Just they should go through as to the how much repair quality surgeon was able to do. So the main important rehabilitation goals for any procedure after the ligament recovery ACL is like to, apart from reducing the pain and inflammation, is to get a good strength and endurance with a good normal range of movements. And the main is to have a good safe zone. You should not put much strain on the repair so as to cause any failure. So nowadays certainly it's moving towards an accelerated rehabilitation regimes. So this is this infrared thermalism will show you that this was an operated facial ACL on the right side, where you can see almost this hyperthermia around this region, and they have done only 20 minutes of physiotherapy. This area is localized, getting reduced to only 30%. So that is the essence of these rehabilitation programs. Currently we use now this called as the criteria based rehabilitation progression, and we all know this chart as to how we process with these basics of any, that the ACL, the initial 1 or 2 weeks, you need to initially start with getting good range of movements up to 90 degrees, the quadriceps muscle, then walking without crutches can be done. Then at that second weeks, to try to achieve the full knee extension, get a flexion more than 110 degrees, improve your quadriceps strain. You can go for more activities. At 4 weeks, it should always be getting comparable to the other knee, good quadriceps strain. Then 6 to 8 weeks, they almost should get a good normal gait pattern. And finally, at around 12 weeks, when you feel the all things are good, you can certainly go for the routine going back to the sports activity. So all this physio usually starts with the pre-op rehabilitation, with the good education, familiarization of the patient beforehand going to the surgery. They should be educated, they should be assessed, and you can categorize. Certainly there are poor candidates sometimes will not be able to follow properly, where you need to give more efforts. So it should be a whole kind of holistic approach, start early, go in a controlled manner, and periodically monitor it, whether those things which you are trying to achieve at 2 weeks for whether they are happening or not, because they come for follow-up during that time. We always say, "Theek hai, ye ho jayenge," it would improve. But there should be certain red flags where you need to act, because if the ROM is not coming at around 3 weeks, more than around 80 or 90 degree only, and you are expecting it to be more. So there are the things where you need to go for more other therapies. So again, the whatever repair, the quality which you have done, then depending on that, you can certainly speed up your physiotherapy. If you certainly have a good stability after your surgery, so depending on whatever quality of repair you get, you can certainly intensify. So the main is to get never overstress the illustration, very important. Progress only when that initial criteria of that physic, whatever you are trying to do, then only if that criteria is met, then only you can just go for the, and you should have a patient specific goal as to control the muscle timing, control and strength. So we all know that it all rehabilitation like ACL, it goes through the phases which I already told the weekly. Another is to have early rehabilitation is usually the 2 weeks where you can starting getting good knee range of flexion, walking with full knee extension. You can certainly start getting some cycling and the stair climbing initially as well. You should try to incorporate the closed chain weight bearing exercises as well immediately. This certainly I found sometimes useful to get neuromuscular electricity if the things like you're not able to get the further range of movement. Sometimes this additional modalities you can certainly use the intermediate physiotherapy phase where you need to increase the cortical strain more, get more knee range of movement. Go for a good balance and neuromuscular like the single leg balances, single leg cone pickup. These additional things you can start doing in the intermediate phase, and the less post-operative phase. The another milestone where you can at least get a good cortical strain as compared to the other side. Almost the patient should have a good gait pattern, which I think the Asha will be covering on. You should have a good complete full range of motion. And then once you feel that transition at the around 8 weeks, most of the your criteria is meeting, then running progression where you can certainly the patient has got no edema, there are any no effusion, where you can certainly go for the higher activities. We all know the soreness rules as to when you should stop. Whenever there's a time the pain is more, you can take a break for 2 days, or you can intermittently reduce the level of whatever activity which you have started. You can certainly go back a level. It all depends on like how the patient is behaving on that particular day. So very essential, like for my ACL patients, initially I ask them to come every weekly, at least for thrice if they are the local persons, or at least that physiotherapy should give me the exactly like how much he is improving, because I feel this initial 3 to 6 weeks are the most important. This is another phenomena. Sometimes the good ACL patient says ki I am feeling very well, and he suddenly stretches out more for that particular day, and this will certainly lead to downward spiral of deconditioning. So try to avoid even progressing to a higher levels. In spite sometimes the patient could feel better. So try to avoid this boom and bust cycle as well. Very important to have a good pain management throughout with whatever analysis, cryotherapy, local cold fomentations, and return to sports criteria we already know. But certainly they say that there is no particular specific one thing which even I could tell. There are 4 articles which they are reviewed, and they certainly say that the return to sports, it's the optimal rehabilitation and design to return to sport should include depending on individual patient and whatever specific sports they are trying to use. So weight bearing exercises, whether they are really helpful, and they have certainly come out with good clinical evidence that weight bearing exercises are certainly highly recommended, and these patients with starting early weight bearing will have a less knee pain, more stable knees, and they are usually more satisfied. The exercises chosen should be depend on whatever graft things which are used as to maturation, and all these considerations should always be taken. Always use the proximal other thing like while performing lower extremity to facilitate greater hamstring contraction, you should try to use the hip, the gluteal, the hamstring, the proximal, which you consider as a broader picture, not only concentrate only on the knee exercises, because all other these muscles of the foot, the hip, they also aid you in getting the rehabilitation highest. Then it's not particular to our country, but wherever the autografts is used, they always to ask them to go slowly, because we know that the healing with autografts is not as good as the allografts. And although try to give the not only the ROM, the strain, it's a proprioception and neuromuscular control is very important, which they are. So there are so many exercises which will be beyond the scope for my talk, but we all know these are the various things which can do. Additionally, nowadays they have come up with the functional approach, Like the more recently, they like rather than a home, it should be supervised therapy. You can use certainly the other machines, the aquatic therapy. You can go for open close chain, and depending on various criteria, don't only judge that only the muscle strain, cortical strain, hamstring. It is a holistic combined approach. Don't ignore your proximal muscle control, which is also important. And it's like what this previously the knee strategy, only knee exercises better. Nowadays hip strategy is important. You have to control both the simultaneously, get a good functional approach. Now, what is a functional approach is nothing but like the functional rehabilitation, where the process of helping a person to recover from their movement capacity is by using their own movement repertoire. Means like whenever it's possible, it individualize specific particular program in the functional. You need to focus on their functional movement, the principle used to use, and the code for their particular motor adaptation. They could be certainly. Very important to give them the challenging, especially if these are the sports person athletes, where these are very high demand patient. You need to go for more cognitive automatic nerve space, the more practice it. And it's not the rehabilitation, it's the rehabilitation, what is there nowadays called the rehability of doing this thing rather than a rehab only. So these another composite workout, these all these things we can say. And lastly, would like to have few things which where there are associated, like what kind of graft each have used again depend changes your rehabilitation program. If you use the PTB graft, so we all know that there will be cortical weakness for initially, that pain will be there. If you use the hamstring, so we don't do any resistive exercises for initial 8 to 12 weeks for the hamstring activity. So accordingly, you need to change your plan. If you use a single bundle or double bundle, that also changes your rehabilitation. Like for double bundle, they certainly say that they have a more good rotational and anterior stability if the double bundle is used. But if you feel that patient is particularly making good progress, then either you use a single bundle or double bundle, it doesn't make any difference. If there is associated meniscal injury, if you have done only meniscectomy partial, so the protocol for physiotherapy doesn't changes. But if you have done the meniscus repair, we already know that if that repair is there, it needs to be healed, and the non-weight bearing for initial 4 weeks is highly recommended. For chondral defects, if you have done only a chondral debridement, again you don't need to wait much, only as far as the pain tolerance is there, then you can start with the physiotherapy. If you have done the microfracture drilling and those kind of things, where you can certainly wait for 2 to 8 weeks. If you have done the ACI, where the large cartilage and all the supplements, then you have to wait, go for as far as the procedure is concerned, where you need a longer period of immobilization, weight bearing is certainly delayed in those cases. If you are doing a simultaneous ACL and MCL, we know that these are usually combined injuries. So very important whenever you are either conserved or you are MCL is also involved along with, you have to control those movement for initial 4 to 6 weeks, so as to MCL to involve. Multi-ligament ACL along with PCL, we know that we need to go for a more conservative PCL ligament rehabilitation program. And finally, whenever we are doing the revision ACLR, we need to account for more things, like you can go for a possible, because we are more concerned about the fixation concerns and complications which could happen because of this previous procedure. So in all, you need a good, all these optimal biomechanics throughout kinematic change to a good success. So it should have integrated into technique, reproducible, and which should be learned by the patient. So the main take home message is like to get a good proximal as a overall picture, the hip strategy as well, functional rehabilitation, differentiate between demand and rehab, think movement not only as the muscle, and it's a complete teamwork from your point of view to the physiotherapist. So all these things is needed for the good proper ACL rehab.